Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. Always lovely to have so many people logged on over here. And our speaker, Dr. Malikah van der Schyff, is testimony to the fact that her popularity knows no bounds. We have a wonderful talk here this afternoon, Advances in Menopausal Health, 2026 IMS Guidelines by Malikah van der Schyff. The evening is sponsored, in fact, by Abbott's, who make, as you well know, hormonal therapy. And Donica of Abbott, I'd like to thank her personally for being with us and being able to sponsor this evening's talk. The evening's kicks off with a video that's Chris is going to be showing us. Chris, thank you very much indeed. He's our trusty medical man that does the videos and also technical stuff. And at the end, I'm going to thank Malikah personally, because unfortunately, our co-host, Professor Steve Jeffrey, is unable to be with us. My name is Peter de Jong, and I look forward to Malikah van der Schyff's talk. But first, Donica of Abbott is going to be assisting with the presentation of a video. Chris, roll the video.
Here we go.
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufaston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufaston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufaston, progesterone and 17-alpha hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In women undergoing assisted reproduction, Dufaston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero.
Gee whiz, thank you very much, Chris. Are we with our audience again? Hello, Chris?
We are indeed. We are indeed.
Okay. Just before Malikah starts, I'd just like to remind people that Chris says we've had some gremlins in our system. That's our registration and our CPD things. I've had some people phone me and email me to say that they haven't had their registration links, but Chris has now reinforced the issue, and he's looked at the gremlins, sorted them out, and your CPD questions and answers should be coming anytime soon. Isn't that right, Chris? Hello, Chris?
No, that's correct. Yes, indeed.
Okay, thanks. Okay, so thank you very much. Without further waste of time, then, ladies and gentlemen, thanks to Abbott and Donica of her sponsorship, and we're going to be listening to Advances in Menopausal Health, 2026 IMS Guidelines by Dr. Malikah van der Schyff. Malikah, roll it.
Thank you so much, Pete. I'm just going to start sharing my screen and just double check that everybody can see. Happiness, Chris? Is it looking good?
Looking good. We can all see. Thank you very
Okay,
much, Malikah.
Thank you. So thank you so much, Pete, to you, to Steve and Chris for the invitation. And thank you so much to Abbott for sponsoring the evening as well. Oh, I just needed to move up. There we go. So these are my disclosures. I have no conflicts of interest. This is a sponsored talk, and thank you to Abbott for their interest in women's health and for wanting to get across the 2026 IMS guidelines. I do have a disclaimer, another disclaimer as well, is that a lot of my resources are menopause societies. So our South African Menopause Society, obviously the International Menopause Society guidelines we're going to discuss, and I might mention the Menopause Society, previously known as the North American Menopause Society. And I would love to encourage you to please join SAMS. Some of the details are up there, and you're welcome to contact us or Royal House, who are helping us with that. And just join SAMS. It's a wonderful organization, and we do try and forward continued medical education in women's health. So what are the objectives
Malikah,
today? I'm listening.
so I see for some reason our view it stopped at the first slide there, the International Menopause Society, but I know you have a disclosure slide right after this one.
Yes.
So let's see why
Let
is
me
it not
see
moving for us?
where I am. Oh, you weren't kidding about the
Yeah.
gremlins.
Gremlins.
You weren't
Let's
kidding
see.
about them. Let me see if I stop share and restart share. Nyaman. No. Let's see. Sorry about that, guys. So the aim of today is I'm still going and doing this. Let's see. You seeing my objective slide?
We can see that loud and clear.
Yes. Okay. So just I'll double check if I'm going to move on to the next one. But just to tell you that we're going to review the guideline framework of the 2026 IMS guidelines, obviously, and to talk around menopause, apply evidence-based diagnosis management of vasomotor symptoms, GSM, cardiometabolic health, bone health, look at the role of menopausal hormonal therapy and alternatives, and address some controversies and emerging therapies. And it is a short time to go through it, so I am hopeful that that's going to work. Can you see my next slide, which says evidence-based medicine?
Not yet,
Yeah.
no.
We're still on objectives.
Yeah, man.
Let's try and reshare the entire screen. Maybe it's some sort of loading error.
Sorry, guys. So what the idea behind all of this, let's see if we're going to be able to share, is that we know that menopause and menopausal hormonal therapies have been, there we go. Am I sharing? Oh, let's just see.
Yep,
Can you
we can
see it
see.
now? Yeah. If I move up now, do you see it? I've moved to the previous slide.
No, for some reason it's not moving. We jinxed it earlier.
We did jinx it. You and I jinxed it for sure. me just close some other windows here and see if otherwise I might end up closing my own flipping window. It's all perfectly fine here.
We've got evidence-based management slide.
Yeah, that's the slide. So that was the slide, and I'm hoping to move on. Okay. Is it moving?
It just says evidence-based management.
No, because I'm moving it here and it's not moving at all on your side. Oh.
What should we do, Chris?
Well, I'm thinking now because when we tested it earlier, it didn't do this.
Yes, ladies and gentlemen, we always test the presentations to make sure this doesn't happen. And
I knew you guys said they were gremlins, but these are Kabiki-Woos gremlins. Let me try and log on to you guys from a different
platform.
Yeah. Let's try and see if that works. We'll stop sharing. And I will stop sharing. Let's leave that and try and go from my iPad and see if life works a little better this way. Let me try and share. Sorry, guys. I'm just going to load my talk and see if it's going to work from here, and then we can try and see if that works. Chris, you still here with me?
I'm still here.
Happiness.
We all still here.
Say, ek hoor. Okay, let me see. Are you starting to see it?
I see the screen.
Yeah, we can see that again from the beginning.
Okay, but now the problem is, guys, iPad doesn't put it in a thingy view. It puts it in a PDF view. But if you guys are all right with seeing it, then we can kick off.
Let's kick off.
Okay,
beautiful.
Happiness. Yeah. So as I was saying, objectives is going to be to discuss it. We know that menopausal hormonal therapy has its use has declined ever since WHI, which was everybody's kind of Mufasa scare word. And we're hoping that there's been a change now because of this new renaissance and uptake of menopausal hormonal therapy and interest, and women who are very keenly interested in improving their midlife health. We do know that estrogen remains the most effective treatment for vasomotor symptoms. That's not going to change in what I'm going to tell you. And it is, many of the menopause societies and major ones have agreed where that's concerned. There have been evidence-based recommendations which actively encourage menopausal hormonal use. And the last one that IMS did was in 2016. And what they've done now is they've actually put out the International Menopause Society recommendations and key messages on women's midlife health and menopause. So it's a 282-page document if you guys want a nice easy read or sleeping pill. The abridged version is 24 pages, so I would recommend that one as well. And its content goes through very many different sections. And I'll try and go through this, and you need to just bear with me. Other than gremlins that decided to creep in aside, you need to just bear with me also because there's a lot of them. And for example, IMS, you'll notice for those who listen to their lectures, is trying to actually weekly go through one section at a time. And we basically have another 40 minutes to go through things here. So what did they do? It was global stakeholder input. There were 38 authors, 27 support teams, 342 recommendations, 285 are supported by research, and others have been good practice points, and they try and separate when they say that. There are 40 key messages formulated, and it addresses current controversies, as well as what was very interesting towards the end is the influence of media, the pharmaceutical industry, as well as publication ethics, which is really great to see. And the South African Menopause Society was not left behind. We are actively involved as well in that. Two of our council members, Dr. Nicole Jaff and Toby de Villiers, which many of you know, both of them, were actively involved in these recommendations as well. And it was systemic reviews, and their methodologies are what they called grades of recommendation, assessment, development, and evaluation, or appraisal of guidelines for research and evaluation. And as I said, they went globally. And you'll find that you've seen these in some of the literature where they talk about the quality of evidence and the grades of recommendation. For the sake of time, I'm going to go through it. And in their discussions, they say that there's been a renewed interest in menopause and menopause management from the public, and how important it is for education, and how important it is to look at everything out there, because they actually do admit there's a lot of fake news out there as well. So if you wanted the gremlins and to kick in, and we wanted the slides to get stuck again, this would not be a bad place for the slide to get stuck. Key global messages. So this is the bottom line. Menopause is a critical window for long-term health evaluation, assessment, prophylaxis, things like that. It remains the most menopausal hormonal therapy remains the most the most effective, not necessarily cost effective, but the most effective for vasomotor symptoms. Early intervention improves outcome. What comes out everywhere, and it sounds like such a cliche little statement to make, lifestyle changes is fundamental, but you need to know that in every chapter they talk about lifestyle changes that is helpful, and care must be individualized. So why does menopause matter? It doesn't even matter that much at medical school or when we were training. And like some of my academic chummies will tell me, whenever they set a question about menopause, it's really badly answered in exams. So why does it matter? Well, it matters because it's a systemic endocrine transition. It impacts long term as well. It impacts cardiovascular, bone, brain health, sexual health, mental health, all of those, that. And we know, and lately we've been talking about windows of opportunity, but the critical window for prevention is within that midlife transition and menopause transition. We know the consequences can be short term and long term, although I think sometimes irritability can be long-term as well, but they can be short-term or long-term. We know that, and some of these things, I know I'm preaching to you, and you know these things, but this is what the guidelines also talk to and what they speak about, and I'll tell you what are little nuances in them as we go. So the diagnosis of menopause is clinical. It's a clinical diagnosis in women more than 45 years. And I did a whole lecture for our SAMS mini symposium on the conundrum of perimenopause and the different ways to diagnose it and how to get there. And the bottom line is, menopause is a clinical diagnosis in women more than 45 years. Hormonal testing is not routinely done. And I know I say that to you, and I know that you have patients who sit in front of you, either with their pages from the different pathology companies going, oh, I asked someone to do my hormone tests, or I did my hormone levels. Will you look at it or analyze it? So ideally, it shouldn't be laboratory based. And some of the tests, like your AMH or your inhibin, is not as diagnostic and does not come from good evidence. And that's written there as well in the guidelines. And that we often overuse your FSHs, your LH, and your estrogens. And I know I'm just as guilty of that, because, the patients look at you as though, but but how can you make a diagnosis just clinically? But sometimes it can confound it because you look at lower levels of FSH and you kind of half gaslight the patient and say, oh no, your symptoms aren't really menopause or perimenopause. So if we look at the definition of it, the signs and symptoms of menopause transition and beyond, you know that there is menopause, there's postmenopause. You often will find that your symptoms predate even your menstrual abnormalities, and later on you have your long-term health benefits. And I know every time we talk about menopausal health, and when I have been to lectures, you get really irritated when you end up seeing the straw staging, and it's been around for so long. And it's still, what the guidelines tell you, is still the best gold standard for diagnosis, to use it as a guideline as well. And it's still current despite other emerging evidences or blood tests or things like that. So you're
Malikah, sorry.
Yep.
What is the straw plus 10 staging? Could you just expand on that?
So that's what
the
slide.
That now?
Okay. That one is what the slide does. It is the
sorry.
stages of reproductive aging workshop plus 10, which was all of around it. So if you look at it, and we've broken it down into different stages of a woman's life for reproductive aging, and it bases it on, obviously, the terminology. It bases it on its principal criteria, meaning more clinically and looking at cycles. And then there are supportive criteria, which can be your blood tests, and then your symptomatic stuff, your descriptive characteristics. So if we look at menopause, you end up having, for example, if I'm going to talk to you about perimenopause, it works in there under late reproductive, early menopause transition, and we think about a late menopause transition as well, which we label as our perimenopause, but we do slot it over a little bit into postmenopause, and you've got postmenopause being listed as early or late. So that is, and what's interesting is that your duration for perimenopause is extremely variable and can last anywhere from 2 to 10 years. So if we're fully defining it, it's the biological stage that as a woman ages, that she reaches the end of a natural reproductive life. You know that it is after 12 months, you are postmenopausal and you've been through menopause after you've been amenorrheic for 12 natural amenorrhea for 12 consecutive months. And I know that can be difficult sometimes with certain patients to try and figure that out as well. And what's really been difficult is the perimenopause. Many of you know that. You have lots of patients who come, and, it's trended on TikTok as well. Perimenopause, itchy ear, dry eye, all of those, sore joints. And perimenopause is a real roller coaster. I mean, Pete, they must sit in your rooms as well, complaining of the vasomotor symptoms. And some women at 32 are thinking they're going through perimenopause. So
it's a very big problem, and it's often driven by some of our women's health practitioners. And they sent, as you said earlier on, they sent in my GP says you must test my menopause, my hormones,
my bloods, test my hormones,
test my bloods, and it's very difficult to get away without handing them something to test.
That is just the thing. If you read the guidelines, it says we are abusing it and we're overusing it. And I know I'm just as guilty as the next guy, because it's almost as though you half extorted or ransomed into doing that. And
you have,
in a way, I don't mind, Pete. However, it's how you're going to analyze it. It is not fair to tell your 53-year-old patient with an FSH of 4 and a full range of vasomotor symptoms that you're gaslighting her by telling her she's not menopausal. You have to repeat it, and you have to repeat it more than once. So don't just come to me with one of them. We need to repeat it again if you're really going to rely on the numbers. And I often say to patients, we don't need to rely on the numbers. Your clinical diagnosis is just as important. And I mean, we could have an entire lecture just on perimenopause, which is just about leading up to everything. And one of the important things about perimenopause is that the IMS admits that there has been, that ideally, that there's been, wrong word, neglect of unpacking perimenopause. And there is going to be a paper on perimenopause, to my understanding, from my chummies on the SAMS Council, that is going to be coming out soon in Climacteric, about perimenopause. And they themselves, IMS, say that it's an evolving understanding. We need to make sure that practitioners know there's a paradigm shift, that symptoms precede cycle change, that it's a high symptom burden phase, that they speak about it openly. We under-recognize, we over-test, and we're not treating well enough. So other than perimenopause, you also have your very early premature ovarian insufficiency. You also have your induced menopauses because of your hysterectomies or pelvic clearances. And then you've got your chemopauses because of your breast cancer survivors. So Pete, I'm going to go through this a little fast because we're going to get stuck then with trying to finish. Ages, okay. Average age for 51. Perimenopause, people are going to tell you it's about 32, but it isn't. And family history is important here. So if we just break it down to vasomotor symptoms and we go through sections, we know that vasomotor symptoms are the most common thing that you think, that the most common symptom. And we know it's because of thermoregulatory dysfunction. And you can have hot flushes, night sweats, because of night sweats and hot flushes, insomnia, and it can be variable durations. I had a patient who had an Excel spreadsheet and had 52 hot flushes in one day. So it can vary where that's concerned. We know it's driven by the low estrogen, but we know that it's driven by the thermoregulatory center and changes that happen there, which then causes changes to the core body temperature, which then elevates, and you get or the hot flush or the dilation. I could have an entire lecture just talking about the proposed mechanisms underlying your vasomotor symptoms, but they range from not just your estrogen, but your central and adrenergic autonomic nervous system. So CNS, HPA axes, endothelial dysfunction, inflammation and clotting. So very molecular as well. And what is the core principle? The core principle of menopausal hormonal therapy, we know, is that it's most effective against vasomotor symptoms. It is fast, it's efficient, it is longer lasting. It's favorable benefit risk in early initiation for this, and we should individualize therapy. You'll hear me repeat that as we go. And then just quickly, if you're looking at how to have your menopause consultation, that's not a fast consultation. Pete, the patients come in cry. They come in angry, and because you're often running late, so they come in angry, they cry in the morning, they laugh at the end. Well, then lucky you. But it's about you taking a lot of time explaining the stages of menopause and going through lifestyle changes, which really, this slide I had myself before IMS, but IMS speaks about lifestyle changes a lot, benefits, risk, and long term.
Monica, can you just go back to those lifestyle changes? Yeah. It's the second time you mentioned. What are
I'm going to go through it. I'm going to go through it. It's part of the one. So I'm going to speed up a bit, but I'm going to go through lifestyle changes as we go. It's one of the chapters. So I've unpacked it a little bit there.
Okay, thank you.
Timing hypothesis, this. Less than 60. And within 10 years of the transition. Within 10 years of the transition, the perimenopause, the menopause, you've got a cardiovascular benefit window that they talk about in IMS, saying if you start early, you can have cardiometabolic advantages. If you start late, you can actually cause harm. And that's where WHI comes in. And they say to you here in the guidelines, late initiation carries risk. So here's your story.
What is late? What is late? When is
late
early?
is more than
Give us
60.
some ages.
So
Okay,
late
60.
is more than 60, but you know that part of the things that go through here, other than me talking about lifestyle, is also going to be individualizing your therapy. If you have a woman who only transitioned in and around menopause and in and around age 53,
Yeah.
she is still within that 10-year window when she's 60. So there are individualizations where that's concerned, but you cannot have the 66-year-old woman that came to me last week who's always hated menopausal hormonal therapy, but now decided after 16 years she doesn't like a hot flush. So, that is not it. And sometimes those women sit in front of you and have changed their mind, have decided they're not listening to the fake news. And they really like that their chummies are going through, better quality of life and would like to emulate that. So it is about age. It's about lifestyle modification. Sorry if I'm making some of you dizzy by going up and down. What are the lifestyle therapies like you asked about, Pete? The guidelines are filled with talking about lifestyle recommendations and modifications are first line intervention, mostly around metabolic and bone health and cardiovascular health, and it enhances and complements your responses to other therapy, and it supports pharmacotherapy. So the big one here, which can also be its own, and I know you've had some fabulous speakers on your platform talking about weight management in women at various reproductive ages. We know that that is one of the number one causes. A woman will live with 52 hot flushes a day, but she is driven crazy by the fact that the weight that doesn't want to go away. And especially that it is age-driven weight gain, that it is a redistribution of your weight to central adiposity, and it's because of that estrogen deficiency. Some of the endocrinologists may not agree with this, and some would say that is it your visceral fat that's increasing? Is it your fat muscle ratio that's increasing? Is it your muscle? Because for the first time, IMS also, Pete, talks about sarcopenia. Like, is it your muscle loss? Is it your increase in fat? Is it, and some endocrinologists have said it is just because you're more sedentary in that phase. You're too busy with life to actually adopt these lifestyle modifications. But we do know that weight management is important where that's concerned. And there are very many ways. And nowadays we are using other ways like pharmacology with the injectables to try and manage weight as well. And
Are they useful in the menopause for that purpose? Would you recommend them, Malikah?
They do have a mention in the recommendations,
Yeah.
but I do find that a lot of the women benefit. There is a lot of benefit in weight loss, obviously, from a bone health point of view, as that fat, estrogen gets stored in fat, more estrogen. So sometimes even it helps with the vasomotor symptoms where that's concerned, but that's not an official story. That's just my observations that I've seen. And, I have an ethical issue about writing them up and wrong word, unnecessarily, in the sense that I was really upset when there were so many stock outages, and the patients that I know who have fatty liver that they need to deal with, or have diabetes that is not responsive, and they need these GLPs and medications for diabetic management. Those ones I was upset when I knew I had candidates that were writing it up for their matriculants to make the dance kind of thing. So, it's not just the Oscars that's important, it's the matric ball that's also important. So, but in midlife women, it's something that you'd need to look at, but you need to look at their risk profiles as well. So if I move on to Mediterranean diet, the one thing they talk about lifestyle changes here is that the Mediterranean diet helps to reduce cardiovascular risk, improve metabolic profile. They speak about it being sustainable enough in most communities and cultures, and it's a modest benefit for menopause symptoms. And if you Google it, or you TikTok it, you are going to find, your menopause influencers would be also your cooks that will tell you and put out their menopause recipes. In the magazines, you start seeing them. There's even a Cape Mediterranean diet that you can look at to try and adapt it. So different countries would adapt it to their cultures and their availabilities of what they can follow. Obviously, exercise. IMS talks about 150 minutes per week of moderate activity. And what a lot of your mature women are doing are resistance training, which is essential for improving the outcomes and for benefiting bone, muscle, and mood, obviously. And again, if you Google menopause exercise plan, that pops up. So it's definitely out there. So if we go, I'm going to go quickly through this, not because it's not important, Pete, with the work that you do in urogynecology, it's not important. Excuse the double negative, but I'm going to go through it quickly if I can. GSM, we know that it is a chronic progressive condition. It affects the vagina and the urinary tract, and it does not resolve spontaneously. And you know what else we know? We know that we don't ask about it often enough. And we know that most healthcare practitioners don't ask or treat it often enough. We know that there are very many ways to treat it. Some are new. You've got your estrogen with your probiotics. You've got your estrogen tablets. You've got your in-stock, out-of-stock vaginal creams. And we know that when we talk about GSM treatment, vaginal estrogen is fabulous. It's first-line therapy. It's minimal absorption. We know that lubricants should be an adjunct to that. We know that there's certain things that can irritate vaginally that patients are using. And, like you'd mentioned before, there are very many... I'm sorry, I'm just lost my train of thought for a minute there because one of my slides is missing here that was talking about the fact that in the guidelines, they talk about vaginal estrogen being used in cancer survivors. And if it's being used in your breast cancer survivors, it can be used in a breast cancer survivor who's taking tamoxifen, but should not be used in a breast cancer survivor doing aromatase inhibitors. So they do distinguish where that's concerned. And they do say if you're using it, again, it is with a multidisciplinary team with a patient in the middle, you and the oncologist, and Pete, you've got those patients and you've got a friendly relationship with your oncologist. So if we look at bone health, we know that there is accelerated bone health during menopause. We know that estrogen deficiencies increase resorption, and we know that the fracture risk rises. We know that. One of the important things that is put in there is that they talk about lifestyle measurements again, and that it's foundational to trying to help with bone health. So we know that is important. We talk about weight-bearing exercises, which I'd mentioned before. And we do know that menopausal hormonal therapy reduces fracture risk in appropriate patients. So,
Malikah, just before you move on,
yeah.
I had today, now this is a patient that came in today and she says, she got osteopenia. I said, you're going to use calcium and vitamin D, yes. But her GP tested her vitamin D and it's fine. Under those circumstances, she says, why must I use extra vitamin D? How would you respond to that? They love testing vitamin levels. Love it.
No, I know. I would probably respond to that to say to her, I'm well aware. However, the morbidity and mortality of a fracture risk versus taking your vitamin D, where it has not only benefits around absorption and metabolism of where bone and that is concerned, it also has to do with other lifestyle changes like the mental health in menopause, not vitamin D specifically for menopause, but that it does have an influence, vitamin D deficiency on your mental health and depression and being run down and things like that. So I would say it's an optimal health benefit. It can only help. She can't be testing it every single time. And at worst case scenario, I would say to her, she should absolutely take it during summer. During winter. And Pete, if you ask these patients, the Menopause Society and the Melanoma Society hate each other because Menopause Society says you need 25 minutes of unopposed sun, and a Thingy Society says, a Melanoma Society says, put your sunscreen on for 25 minutes before you go out the house. So vitamin D is always going to end up being low, or it takes long to increase. So I'd probably have that type of conversation with her, but ultimately the patient needs to take and make response. We can give them the information. It's a relationship. They must understand if they want to or not, because I don't know if you've realized now, it's not also just about, are you on any medication? We need to now reiterate and unpack these conversations and ask, are you on medication? Are you taking it regularly? Are you actually taking it? These are the questions we need to ask in our histories.
Thank you.
Yeah. So in the guidelines, you'll see they talk about fracture risk classifications. They do talk about the FRAX criteria, and we know that there was a lot of work done by our universities on making the FRAX for South Africa relevant as well. And if you look at what they say about osteoporosis prevention, we know that it is lifelong, your treatments potentially, but it should be planned, and you should look at where and when your drug-free intervals should be. So if we look at, for example, bisphosphonates, your IV should be drug-free after 3 years, they say. Your orals after 5 years. A DEXA 2 years after an oral, being off orals, and 3 years after off IVs. So those are just very quick guidelines. If I'm doing this fast, if Toby de Villiers was joined here, and if he is, apologies, because I am finnig at this so we can get through it. If we look at other things, denosumab, there's no limit on its duration, but there is accelerated loss after its cessation. And we say use a bisphosphonate after that. If you need to use something because you're trying to stop that rapid loss. It reduces fracture risk in appropriate patients. And if you look at terapetide, which is your anabolic one, it's for your very high-risk patients. It is 2 years off and then followed by anti-resorptive treatment. 2 years and then often followed by anti-resorptive treatment. And it's not, some of them is not available in South Africa, but we do have one of them that is here, but I'm not going to mention drug names. I'm going to go through CVS, cardiovascular. Cardiovascular, is the leading cause of mortality. More women think they're dying of breast cancer, but it ends up being a heart disease that would probably do you in faster. The risk increases post-menopause, and estrogen has protective vascular effects. Menopausal hormonal therapy and cardiovascular disease, it is safe if there's early initiation, and it is what we spoke about before. It is timing dependent, and what I told you before is avoid late initiation, because then you actually increase risk. Look at your patients individually, and I'll show you later, but it has been shown that it can reduce cardiovascular disease risk later on, even if taken long term, and there's evidence that I'll speak to later. But remember, we're not doing it for primary prevention. If I just go through that, we know early initiation reduces risk, but I'm going to go through that quickly. What about VTEs, venous thromboembolism? I'm also not doing this much justice, but I am going to do the essential. The essentials are oral estrogen can increase your VTE risk because of the liver metabolism. Transdermal has a lower risk. We know that progesterone is important, and choosing the correct progesterone is important. So it is suggested in the guidelines a micronized progesterone, or progesterone that's as close to natural, which is your dydrogestone as well. And your levonorgestrel intrauterine systems can also work. Again, assess individually. And it's interesting because they do tell you in the guidelines, if a patient is on anticoagulation therapy, there's no need to discontinue your menopausal hormonal therapy if they're on it immediately. What about breast? Breast gets a lot of airtime. What is your breast cancer risk? Your risk depends and varies by the type and the duration of menopausal hormonal therapy. We know that your risk is because of how long you use it, and we know, and you know, that the risk is more with combined therapies, and your estrogen only risk is a lot less than with your combined therapy, and the absolute risk remains low. And this is a slide that a few of us have used during our presentations and things, is trying to put it in perspective about where it fits. Like you can see where obesity fits in comparison to combined menopausal hormonal therapy, or combined hormone therapy for that, or smokers. So we do know that menopausal hormonal breast safety, if we look at it, we do know that there is a lower incidence and a lower risk than what we think in different countries. That evidence is out there. If you look at a French cohort study that was done in 2008, they speak about the different types of progesterone, and that your progesterone choice is relevant as well, and that the risk of invasive breast cancer was significantly lower in menopausal hormonal therapies containing progesterone or dydrogesterone than with menopausal hormonal therapy that contain other progestogens. So the choice of progestogen and breast cancer risk in a Finnish study as well was also done. And if we looked at it, your dydrogesterone came out well. If you look at the guidelines and this, MPA comes out the worst out of your progesterone choices. So that is just a repeat of that. I'm going to go through this. So if we look at breast cancer risk, consider baseline risk where the patient is. We know that there's increased breast density that can happen with menopausal hormonal therapy. We know that increased breast density does put you at more risk. So the radiologist will often say come back more frequently. Combined menopausal hormonal risk is about duration. It's actually written in the guidelines that the levonorgestrel IUD is not recommended if the baseline risk is high. So yes, I know what it says, but that's what it says. We know that tibolone must be considered exactly the same. Just because it is a menopausal hormonal therapy, it's theoretically hormone adjacent and not pure estrogen and progesterone, but risk profile treated the same. And again, what I was talking about vaginal estrogen, it's safe in survivors on tamoxifen, but not your aromatase inhibitors. They have to use non-hormonal methods. So endometrial protection, we talk about that as well. It talks about that in the guidelines. We know that the only reason for your progesterone is for a woman with an intact uterus. We know that we cannot give them unopposed estrogen, and we must individualize our regimes, and that's why it's important to know your progestogens that are out there. And we know that you don't need it if if you've had a hysterectomy. It actually says that it doesn't also sometimes need it. We know that you do need it, sorry, also if there is evidence and you had evidence of pelvic endometriosis as well. So brain and mental health, and guys, I apologize because I'm going quick through some of these, not just because we had a gremlin that delayed us in the beginning, but also because I'm trying to put all of them together and I could unpack all of them, and especially this cognitive function and mood as well. More women are going to sit in my practice complaining about brain fog, memory, and mood, and they're going to sit in your practices more than the hot flush or the night sweat is getting to them. It is affecting their work, it affects their sleep, it affects their function. And we know that this is often the prodrome, as we said, the burden of symptoms before even menstrual abnormalities within the perimenopause. We do know, just as a quickie, menopausal hormonal therapy is not indicated for dementia or Alzheimer's prevention. We do know that the latest evidence shows that menopausal hormonal therapy does not improve, but it doesn't worsen these at the moment. And that's relevant because the wheel changes. As we've been going over decades, they say, yes, it's fine. No, it's not fine. Yes, it is going to improve. So there's evidence that is coming out all the time, looking at different studies that need to be looked at. And we do know that, for example, there's certain things, if we want to talk about lifestyle changes again, Pete, train your brain, not just your muscles. We talk about filling up your cognitive reserve in your perimenopause or menopausal transition as well. And we do know that even if there is not a causal link between certain things, menopausal hormonal therapy is not going to potentially prevent your dementia, but it is going to stop that foggy brain. And the important thing to tell women is that once the menopause transition is done, then you should return back to your normal cognition and memory. And that's important to tell them, for them to look after as well. If we look at menopause and sleep or sleep disturbances, we know that it's multifactorial. The amount of people that have a blue screen, that have bad sleep hygiene, we know that, I can end up really doing series in the middle of the night and then still be awake at 3 o'clock. So we all have bad sleep hygiene. We know that sleep disturbance is a common symptom in menopause. We know that vasomotor symptoms affect wakefulness and your ability to go to sleep. We know sometimes even your bladder can be irritating. You know that, Peter's a urogynecologist. And we know that if we manage hot flushes, night sweats, and that waking up from that irritation, you can improve sleep as well. And some of the neurokinin B, the candineuron, the neurokinin B antagonists, they actually also help with sleep by helping your vasomotor symptoms as well. If we talk about sexual health, it's multifactorial, biopsychosocial. It is important to address local contributors and to address it proactively. We do know there is androgen therapy available, and now there's androgen therapy available in South Africa, registered, regulated for hypoactive sexual desire disorder. There is evidence for that. We must avoid indiscriminate prescribing. We do know that we believe testosterone will help with many more things other than just libido. But for now, that is its only registered use, and it's what IMS also says and recommends. So it's a biopsychosocial. We know that there is a cream assessment. We know that there is a cream available. And I just want to warn people, I know the cream is a lot more expensive than some of the male testosterones. Just watch your testosterone levels with the male formulations. I have seen women who have like 5 times the testosterone level from just using a pea size of the male testosterone. I'm going to really make you dizzy and go through premature ovarian insufficiency very quickly. We know that it's before 40. We know that it increases your morbidity, your mortality severely, not just cardiovascularly, but it actually has been shown dementia, Alzheimer's, all of those cognitive function. All of that worsens because of the prematurity of that ovarian insufficiency. And we recommend menopausal hormonal therapy until natural menopause, or even a low-dose contraception for menopause. And IMS, with their guidelines, goes through it and has a lovely summary for the indications of hormonal therapy, which is also thanks to Nick Panay's paper on this, which was very important, and they thank him there for it. And they have a summary of HRT options, and they have an algorithm which tells you how to treat it. So it's all there under the section, and I'm just going to refer you to that. Contraception in perimenopause. We know that in perimenopause, ovulation can occur. We know that contraception is required until menopause is confirmed. This is where some of your blood tests might help. If we look at it, the IMS is very good at guiding where this is concerned now. So your copper IUDs can stay in it can stay in until menopause if you place it after 40, but it may be stopped after 2 years of amenorrhea between ages 40 and 50, or 1 year over the age of 50. The levonorgestrel, what you really need to walk away from here is to know, yes, they are approved for 8 years. However, 5 for contraception, only 5 years for a 52 milligram if you're using it as an alternative to protect your uterus and you're using a transdermal estrogen. For your pills and potions, your pills or your injectables, we stay till about age 50 because of their risks. If we talk about progesterone-only pills and the implants can continue until age 55, and this is sometimes where your blood test may actually be helpful. As far as your contraceptive choices, I'm not going to go through this for long, but you know that there are newer combined hormone contraceptives that are 24/4 formulations that have a better estrogen, like an estrogen valerate or an E4 in it as well. So those are the new formulations to look out for. Non-hormonal therapies. IMS talks about non-hormonal therapies for VMS as an alternative. Basically, they talk about SSRI, SNRI having a moderate effect, gabapentin being useful at night, but the reason why it's useful at night is because it knocks you out. So the side effect profile is not as fabulous. Sleep is fabulous because it's practically sedative. And it should be considered when menopausal hormonal therapy is contraindicated. And what I've put here is, while it was still called the North American Menopause Society, it is now called the Menopause Society. They had a position statement on what is recommended and what is not recommended. And this is quite a good list to go through. And non-hormonal therapies, like I highlighted there, your neurokinin B antagonist, that is a talk on its own as well. You know that which is fezolinetant and ezolinetant is not available in South Africa. One of them is stuck at SAPRA for forever, and we have no timeline for when it's coming, but it would be perfect for our patients who are where it's a contraindication, or your breast cancer survivor. So that would have been fine. I'm going to go through this super fast, that it acts on your candy neurons, but I am going to go through that because we don't have time to go through the mechanism of action. Quickly, complementary and alternative therapies that they talk about. They talk about limited robust evidence, variable efficacy, strong placebo effect, and important to counsel your patients. And we talk about bioidentical, and the word really is not the appropriate, should be, body identical. Is compounded formula. Those formulations are not recommended. Lack of regulation and standardization, and use of approved therapies is preferred. And SAMS has a position statement on that, which you can find on our website, along with the IMS guidelines, by the way. And we presented it at the IMS in 2023 and had a fabulous response. So to that position paper, because many countries have not brought it out. So Peter, you okay if I just go on for a little longer?
Yep.
Okay.
Yeah.
So menopausal hormonal therapy selection. Practically, what are you going to do? You know this already. I keep saying under 60, 10 years within the menopause, no contraindication, individualize. So I'm going to go through this. Contraindications are your breast cancers, active or past. Unexplained vaginal bleeding. We must sort out where that's coming from before, and what is the cause before we deal with it. Your venous thromboembolisms, your severe liver disease, and don't forget porphyria, because I randomly had a patient I put on menopausal hormonal therapy, and then she said, "Oh, I'm starting to get, photophobia and itchiness and everything. Did I forget to tell you I have porphyria?" Which is like an absolute no-no as well, but we always forget to put it in the contraindications list. So we know that your oral estrogens are widely accessible. If we talk about route of estrogen therapy, we know that your transdermals are safer for venous thromboembolism. We know that we have major stock issues around that, and we need to look at our route. We know that not all progesterones are the same, and I'll go through that, but we know that not all estrogens are the same. And if I can just go through it to let you know, ethinyl estradiol is the baddie, so to speak, the synthetic estrogen, and it is your components that are not found in women. Estradiol and conjugated equine estrogen is a lot more natural, so to speak, in that their components are found in women. CEE is a very complex compound, so difficult sometimes with administration. And then we know that we now have E4. So we know that liver metabolism of estradiol is what can sometimes cause a problem. You've got your ethinyl estradiol, which is very potent. It's a more potent estrogen than estradiol. It metabolizes in the liver and it induces its hepatic proteins, and that's where your VTE risk comes from. What is a little better is estradiol valerate and estradiol, 17 beta estradiol, your E2 as well. And we know that there's a newer one on the market, estetrol, and that is a better estrogen, and that is mentioned in the IMS guidelines. I'm going to go through it quickly. It's more of a natural, so to speak, estrogen that does not have influences on the liver, and therefore, because of its minimal hepatic metabolism, it is considered a little better and has lower venous thromboembolism risk. So watch that space for something in the menopausal world. But your progesterone is actually the baddies, and the progesterone is the one, even although we often don't give progesterone enough airtime, we need to know your different types. And we know that you can have continuous and sequential regimes, and that it can influence your bleeding pattern, and that it is progesterone receptors. I mean, Donica was really great now with showing the video on how progesterones bind and the different progesterones. And we know that they can have other binding sites, which is where the problems come from when it's androgen, glucocorticoid, or mineralocorticoid receptors that they bind to. So we know not all progesterones are the same. We know that dydrogesterone is synthesized from a natural source. You saw that in the video. It is a more unique model that does not have androgenic or glucocorticoid effects. And what makes it a unique one is, as I said, it is antigonadotrophic. It is estrogenic, but without bad estrogenic effects, androgenic. And that, so it is one of the closest to natural that you have. And then if you want to go purely, when we talk about natural, a micronized progesterone is a so-called body identical or bioidentical one as well. So your progesterones are relevant. And it's important to know this because, guys, you know that a lot of your people are so transdermal for skrik at the moment, but you need to know your oral molecules to know which one is safe to individualize it towards your patient. We have so many diabetics, so we need to not have a glucocorticoid activity in that progesterone. You don't want the progesterone to start influencing glucose control as well, because you don't need a silent heart attack as that. So if we look at our prescribing manifestations, especially in South Africa, it is common. The commonest thing is oral estradiol-based regimes. Combined preparations are widely used because many women do still have their uteruses. Oral formulations are being used because cost and availability and limits to transdermals. I do believe that the older you are, you should swap to transdermal after 60 if the patient's still on it. A lot of stuff is formulary driven, especially by your medical schemes as well. Practices really differ. And I'm sitting here very bougie in private practice, but the public sector is horrible with its limited amount of medication that it has. And that's really sad for midlife women stuck in the public sector. So you have to confirm your indication. You have to assess your risk profile. You have to select your therapy and the route thereof, and you have to review it. IMS talks about all of that. There's a table summarizing the hormones, which you can even take a screenshot of just this and just keep. You need to monitor and follow up. I keep repeating myself where that's concerned. If we quickly talk about duration of therapy, no fixed duration or limit. And Pete, I flippin' had to phone the medical aid about a 79-year-old who is still getting a hot flush and is on her transdermal estrogen. Luckily, the medical aid approved it quickly, but she had to come to a gynecologist to do that. So there isn't a fixed duration or limit. Look at your patient, look at the risks and benefit. You can tell the 79-year-old it's okay to still go buy your patches and individualize it. So actually, if we quickly just go through this, there's actually a paper that speaks about duration of therapy and how it came out recently, and it ended up being the 10 million Medicare women that were looked at, and they showed that those who did not compared to those who never used and those who discontinue, there were improvements and decreases in mortality and morbidity for all of these things, your cancers, your venous thromboembolisms, even in your dementia, even although the average evidence out there says that it's more neutral. And it was shown that whether it is combined therapies or estrogen only, it does have duration of therapy improves quality of life. We know that we have special populations you must look out for. I'm almost there, guys. Migraine, consider transdermal, high cardiovascular risk. Look at your selection. Common pitfall, don't rely on your FSH testing. Treat GSM. Avoid, that's a double negative, but don't avoid your menopausal hormonal therapy if it can help. It's a systemic transition. It's menopausal hormonal therapy is safe in the appropriate woman that you have to assess. And the key action points also talk about governments coming on board, media coming on board, the pharma industry coming on board, and looking at your alternatives. So if we look at a future direction, it is a personalized form of medicine. Know your therapies, know your formulation, assess the woman globally, and optimize her long-term health. So, Pete, thank you so much. Sorry about the gremlins in your system. If you want to know more about menopause, come to Rio in September and October. And if you really want to know it, diarize already our SAMS conference, which is already in the diary in February 2027. So, Pete, thank you so much.
Malikah, it's been wonderful having you over here. The great number of attendees is testimony to your popularity. We would love to have you back again, not next week, but some other time. Next week is Eid, as you well know. And to those people that celebrate Eid, have a wonderful Eid Mubarak. So thank you once again to Donica of Abbott, who sponsored this, and of course, Chris, who puts it all together. And safe home, everybody, and we look forward to seeing you the next time. We will tell you whether or not we're coming back to the webinars next week. Depends on Ed. And a safe home, all the very best. And thank you so much, Malikah. Good night.
Thank you so much. Good night. Keep well.